I hope lunch was good. Was it something good?
And I was not there.
Pompeii pizza.
Oh,
They were
okay.
just doing so good.
Karen, how you pronounce your last name Agay Shay, or how do you pronounce it?
Agay, Shay.
Agay Shay. Okay.
Agay is a Persian name. It's our name, and Shay is mine. Shay is a gift in Hebrew, and Agay is a present. Agay is a prince in Persian.
Okay.
Persian. Oh, his origin, his family origin.
Oh, Persia.
Yeah. Iran.
Yeah. Very cool. All right, I think we have enough people to get started, and our division director is online, and she's gonna do, you can't see her in your version, I can see her. She's gonna do an introduction to Dr. Agay Shay. Thank you.
Hi, everyone. Thank you so much for joining us today. It really is our pleasure and our privilege to have Dr. Agay Shay here with us today. She is visiting a visiting scholar, and she will be leaving too soon at the end of October, sometime in November. So we have a few more weeks to get to know her here. And I am just really excited that she will be talking to us about climate change and health in Israel, something that we've been working on here at UIC as well. She is faculty in the Israeli faculty of medicine.
Yeah.
Israeli, yeah, at the Bar Ilan University. And I am going to let her continue to tell you her journey in environmental and occupational health. But we're just really excited to have her. And thank you so much for presenting. And many of you, if you haven't already, should get to know her and her work, because she really does some wonderful, innovative, and potentially, hopefully, collaborative work with us here at UIC. So thank you.
Thank you, Christine, for the very kind introduction. So hello, everyone. I thought to take this opportunity to tell you about myself. And in the previous meeting that I was in all the scholars, I didn't introduce myself as I wanted. So I've decided to draw the path that I've done. I think it's very important also for you as a students to see the path that researchers are doing, because you see us many times like in a position, but you don't know exactly what we did in the way. So I think it's sometimes interesting to understand this path, which make us unique, each one of us. So I've started my journey of research in 1997, which is almost 20 few years ago, 23 years ago, in the Hebrew University of Jerusalem. I've learned biology and environmental science. I've continued directly to study of environmental microbiology. I've learned how the people affect the environment of the microorganism in the different aquatic regions. And I've used many methodological many methods that are used today in the microbiome studies. That means that I've identified which are the organisms that can degrade phenanthren, which is one of the it's a model of compound. And I've looked at the different region in Aza, in the Elat, and Etang de Ber, which is France. And I was very bad in the lab. That means that I did many methods and everything was bad. So I said, yes. Okay. So how do I change that? But anyway, I was very bad in the lab, so bad that I decided that I'm never going to be in the lab again, and I never going to be in the university again. So it was very bad experience for myself. And I think that I needed time to realize what I want to do in my life. And I was very lucky also. I think that we can do that this way. Okay. Yeah. Okay. I see that here now. Okay, and I was very lucky that my, but now it's not working. Oh, okay. My daughter was born at the same time, just before I submitted my dissertation. And I was very lucky also that it wasn't exactly luck. We moved to the north part of Israel, and I've started to work in the industry. I've worked for a few years, and then my son was born, Uri. And I've decided that the industry is not interesting enough for me, and I want to do something meaningful. So I've started a journey of looking for what I'm going to do in my life, the rest of my life. And I went to different conferences in Israel, to the Society of Environmental Studies and Ecology, to different presentation of people in different fields of environment, which I was familiar with ecology, with the environmental science. And then a friend of mine sent me an invitation for a lecture of Professor Brenda Ashkenazi, for which of you know her work. She's from UCLA, and she was working on exposure during pregnancy in a SHIMCO cohort, which is a cohort of a woman who work in the field with agricultural exposures. And she presented her work about exposure during pregnancy to pesticides and birth weight. I heard this lecture and I immediately realized that this is what I want to do in my life. I want to be an environmental epidemiologist. It was amazing. I felt like my mind is blowing to hear this. I never knew that there is a field of epidemiology. I never knew that there is a field of environmental epidemiology. I was fascinated with this, and I've decided to start my journey in this field. I was looking for supervisors, and I was looking for different issues that related to this environmental epidemiology, which was not familiar in Israel. So I was starting my PhD in the University of Haifa in 2007, and I've looked at ambient exposures and congenital malformation. To go from deciding that you want to start your PhD on something, and I've started this without any background of a Master of Public Health. I've received a manuscript from Professor Yonam Amitai, which was the head of the Israeli, he worked in the Ministry of Health, and he gave me a paper about air pollution and birth weight that was published from the Czech Republic. And it was a case control study. So I had this paper, and it was written case control, and I never knew what is case control, because someone who didn't learn epidemiology doesn't know what is case control. So I was starting to learn by myself all the methods and everything, just to understand what I'm reading. But it was so amazing, and it was so worth it. So I conducted and finished my PhD about ambient exposure and congenital malformation. And then after submitting my PhD, I went to an amazing place, which I highly recommend, that's called CREAL. It's the Center of Research of Environmental and Health in Barcelona, which today named IS Global. I've stayed there for 1 month, and then I had a publication from working with Mark Nichnaus about greenness and adverse pregnancy outcome in Tel Aviv region. I've presented this a few weeks ago. And then I've decided to stay longer on completely different issue and completely different aspects. I've worked on multiple exposure to obesogens and obesity in children, which is very different and using very different methods. Again, it's observational study. After finishing this postdoc experience, which was amazing, due to personal issues with my kids, it was very hard to be in a different country for my son and to live in a very small place in a city. We lived in a very non-urban area in Israel, so he used to be outside. And we moved back to Israel. And in Israel, I've started a very unique and very interesting program, which is called Mimshak. Does anyone here familiar with the EOHS program of postdoc, of policy making postdoc? Except Linda, the students? Okay, so I will take this moment because this is very relevant for many of you, maybe in the future. The EOHS postdoc is a unique opportunity for people who graduated science or technology engineering to work with policymakers and to really make impact in real life and in real setting, not just to do a research. And I think it's very interesting and very unique. For myself, I've learned a lot during Mimshak year. Yes.
Can you say EOHS, you mean the American Association?
Yes, I can show you because today I'm presenting afternoon about this, the different programs. There are 4 programs that Mimshak was inspired by. It's 4 programs here in the US, one in California, the other one is more about ecology and for those who graduated 2nd degree, and the others are for PhD graduates. And it's in different places in the United States and for different time in your career life. And working with the head of the head of the Public Health Service, the Ministry of Health, really make me understand how things work in real life that are not science. And it's very different. It's not science-based, unfortunately, many times, not just because that there is no science that is relevant. I think that this is one of the problems in the academic world, that we are many times not going the further step, or we are not bridging exactly between the science and the knowledge and how to translate it. There are, at least in Israel, it's very challenging to do this. And I know that few of you, I think that the 3 researchers that here are doing this, but it's not so common. I mean, it's something that we need to think about. And personally, I have to say, as an environmental epidemiologist, I didn't take the next step to translate my research to the policymakers and also to the public. Unfortunately, people do not understand what is relative risk. If you explain to someone and you give an example of relative risk, what does relative risk mean? Even before COVID and after COVID, people don't understand that. It doesn't make sense for them. They need numbers of people, attributable cases. They need money. They need to understand it. So I think that for me personally, I need to do the next step, and I want to move my research forward to be more understandable for others. And I'm also looking for the next challenge. The next challenge that I've took on myself And I have to say that I'm still struggling with this, and I'm thinking about this, and I don't know exactly how to tackle this problem. I've decided to be the advisor for the Ministry of Health in Israel to write the adaptation strategy to climate change and to think how to act not for the mitigation aspect, but for the adaptation aspect of the population in Israel. And I will explain why this is important in the next few slides. But it's not very easy to write an adaptation strategy. First of all, in Israel, currently, there is no adaptation strategy for climate change. And we are way behind the rest of the world, like 10 years behind the rest of the world and the rest of Europe. Is there an adaptation strategy in Chicago for the climate action plan in Chicago, specific for Chicago? Okay, so in Israel, we don't have one. Just recently, there was the law that is mainly on mitigation, but we don't have a strategy plan for adaptation. So there is a lot of work to do. I do want to explain and to talk about potential collaboration about research, past research, and things that maybe you can think about things that you can collaborate with me. So one of the the unique data set that I've been working on it includes live birth, 1 million births, live birth, and stillbirth, which is the unique part of this data set. It includes spontaneous and late abortion. I've been publishing about the temporal patterns of this outcomes of congenital malformation and live birth, and also spatial distribution of this outcome in Israel. We have information about exposure assessment for greenness, for air pollution, for temperature, mainly in the Tel Aviv region, which is where the population is the most dense in Israel. In addition, further a different data set that include all live births that were born in Israel between 2000 and 2030. This is two data sets that I'm going to present result about in the next few slides. And we have a lot of information, and I've worked a lot with this data set specifically about gestational age, birth weight, and zeta birth weight for sex and gestational age, preterm delivery, and so on. It's also unique because we conducted a geocoding at the house location, at the street, and at the settlement. We have information about maternal ID, which means that we can do analysis of sibling. That is very interesting. We have information about occupation of the mother, occupation of the father for more than 70% of the birth, information about personal education. We also have information about the socioeconomical area level, and we conducted a principal component analysis, and a lot of information about exposure, including greenness with different type of greenness, with different type of resolution. And now we are starting to look at the Google Street View images to see if we can identify specific type of vegetation to make sense of the association that we see. Air pollution, and also to look specifically about the sources of air pollution. And one of the unique exposure in Israel is dust event that we're trying to understand. I've tried to look at the dust and to see, to have a little bit sense on what I see in the association, because I see nonlinear association with a higher exposure, which just I realized, and we see now also, I assume you all heard, and maybe you also experienced the fire that was in Canada and how it affected in New York and that part. Did you feel that here? Okay, so Also, when people did analysis of fire particulate matter, they also see a nonlinear association. When people see the pollution, they are stay indoor many times and they are maybe less effective. So this is also can explain what we see. And we have looked at temperature in different models of exposure, which I'll explain. So I'm going to show you mainly two studies that I've conducted. It's not about health outcome in general in Israel because there are not so many studies. There is only one study about stroke and temperature. So I focus on my work and also will present others briefly. So I think that every epidemiological environmental presentation needs to start with Hippocrates that said, if you want to learn about the health of a population, look at the air they breathe, the water they drink, and the places where they live, which he said that 2,500 years ago, and it is still true. He also analyzed and talked about the effect of the season, which is very important for health. So 2,500 years later, the WHO declared that the climate change is the single biggest health threat facing humanity. So we know the health effects of outdoor temperature and health since the 50s. In occupational setting, we know that also for many years. The first publication about heat wave effect was in the early 80s, and it was not so far away from here. And this sentence from this publication about public health preventative measure should be directed toward the urban poor, the elderly, and person of other than white races is still correct. So many years after that. In Israel and in Europe, the heat wave that occurred in 2003 was a major event, at least for changing the set, that it's not just one publication. I mean, the population and the entire public started to be aware of something that related to heat. And if in Europe, we see that the mortality, the attributable cases are in very big numbers, I have to say that in the US, the numbers are much smaller, first of all. Maybe because the population here is more adapted, using air conditioning for most of the population, those who can afford air condition. But if you can see here, this is a projection. I don't know if you can see my mouse. This is a projection of, this is a projection of what's going to happen in the US. This is also relevant for you guys. Okay, so that was about mortality in general, but we know now that heat affects cardiovascular mortality, cardiovascular and stroke morbidity, psychological outcomes, and also adverse pregnancy outcomes. So now I want to focus on Israel. So Israel is on the other side of the world. It's in an area of desert. We're in the border of desert in the Mediterranean region. And the size of Israel is small. How small? This is the size of Lake Michigan. So you can imagine Israel is smaller than Lake Michigan. The population of Israel is less than approximately 10 million people, which is also smaller than Chicago region. And Israel is a very oriented to children. How oriented is it? You can see how many benefits there are for families, and even a single mother in this list of benefits that a person would have if you will have a child. Just bring a children. This is like we have a song like this. ילדים זה שמחה. Children are happiness. And as you can see, we have the highest fertility rate in the world. In the OECD world, I'm sorry. So Israel is in the OECD world since 2010, but we have the highest, much more than every other country. I mean, Turkey is the second one after us. So we have many kids. And the number of the kids and the proportion is very different between the different groups in Israel. And there is also trend in the different group of Israel. So there is a decrease in the Muslim and Arab population and an increase in the number of children in the Jewish population. Part of this is due to the Haredim subgroup in the Jewish population. So are we affected by climate change in Israel? It's very hot in Israel, and it's becoming hotter. Generally, the Eastern Mediterranean region, including Israel, is called as hotspot region for climate change. That means if the entire world is going to have an increase in 1 degree, this is like the border of, we always say that we don't want to get to 1 degree increase, Celsius degree increase in the mean temperature. Israel is beyond that. So the summers in Israel have become significantly warmer with an increase in the frequency and severity of heat waves and an increase in the relative humidity, particularly along the Israeli coastline. And I'll show you how we see that. So you see that there is an increase in the mean temperature, which means, which we see. Okay. Now we see, okay. So we see that there is an increase in the temperature starting from the 90s, like an acceleration of the increase. And I translated this to Fahrenheit, that it would be easier. But the temperature also of the maximum temperature of the day and the minimum temperature of the day. So this is a projection of what's going to be in Israel. And this is in black, we see the observation. In green, in red, we see business as usual. And in green, we see if in 2040, the increase of the greenhouse gases will be decreased, will be the same and will be later decreased. So you see, in any case, we will have much higher temperature than today. We are already feeling an increase with the hot nights and hot days. And you see here the 3 angles represent the increase in every region in Israel. And you see also the size, it represents how much it occurs, how often it occurs. And we also see an increase with heat waves compared in 1991 until 2070 and before that. So generally, it's become hotter in Israel. So I told you about the borderline of 1 degree Celsius in the rest of the world, but in Israel, we already feeling 1.4 in the mean temperature of increase of degree Celsius. And we also experience hot days and hotter nights. We also have a drier, there is a precipitation. We have an effect on the precipitation. And on how extreme is the rain that is already occurred, which affect flooding. So my research mainly focused on pregnancy outcomes. So this is what I'm going to talk about now in the next few slides. So what is adverse pregnancy outcomes? Adverse pregnancy outcome is generally abnormalities during pregnancies. It includes gestational age, effects on gestational age, when women give birth, gestational growth that related to the birth weight, and also on how the fetal is development relating to the growth, gestational growth, congenital malformation, stillbirth, preeclampsia, gestational diabetes, which are health effects on the mother, but it's still called adverse pregnancy outcome because it just occurred during the pregnancy. And brain development, which is different than congenital malformation. So why to study this adverse pregnancy outcomes? First of all, it's increased the risk of mortality and morbidity of the infant itself. But this is I'm sure that you know Berker theory and the development origin of health and disease, which means that this will affect the infant health later in life. In Israel, as I explained, although the prevalence rate of this adverse pregnancy outcome is very similar to Europe, but because we have a very high fertility rate, we have a burden on the public health system. And one of the issues why to study adverse pregnancy outcome is because the woman become sensitive to climate change due to the changes that occur in her body, which means this is also a unique time that we can improve her health. And why is it she's more sensitive? It's due to the hormonal changes that occur in a pregnant woman, the fat deposition, and the surface mass ratio, which means that she becomes bigger and it's more difficult to sweat and to lose heat. So this is to demonstrate how the developmental region of health and disease paradigm occurs if we are doing intervention during early life when the plasticity is the highest, then this will change all the course of the health later in life. So the biological mechanism exactly how heat and other climate change exposure effects is not well known during pregnancy. It's mainly due to dehydration and direct effect on blood flow. But it also can be due to heat, shock proteins that affect directly the cells. And when the exposure is important is also very important questions, because there is a sensitivity time window of development also during the pregnancy itself. That means that if we have an exposure that occur after the outcome, then it should not affect the outcome itself. This is kind of way that we can check as a sensitivity analysis to see that what we see is a real effect. That means that if the heart develops during weeks 3 to 8, if I will see effect with exposure later in pregnancy, that means that this is an effect that may be due to selection or due to other issues that are not due to causality. Most of the previous epidemiological studies looked at high temperature and preterm delivery, and only few studies looked at cold temperatures that can be issued in other countries. And most of the previous studies were temporal and only few were spatial. So in Israel, there were 7 studies. Think about it, no study about mortality in Israel with temperature. No study with cardiovascular disease and temperature. No study, just one study with stroke. 7 studies on adverse pregnancy outcome. This is just to show you how central is this issue in our culture. Most of the previous studies were in the region of the south part of Israel, which is Soroka. Why? Because there is a hospital, a big hospital, and there are people who really interested in environmental epidemiology in this hospital and want to collaborate between exposure scientists, epidemiologists, and physicians together. So if you have this collaboration, you can do a very good research. Unfortunately, it doesn't happen in the national system yet. Hopefully it will. So when I've studied my PhD, this is a publication from my PhD. When I started my PhD in 2007, there were no studies about temperature and congenital malformation. I've started to look at this. I didn't have hypotheses before I started. I've looked at air pollution, and temperature was a confounder. I didn't think that it can be an exposure that's causing teratogenic effect, but why not? I mean, it's well known for women that they are not supposed to be exposed to heat during pregnancy. They are not supposed to go to the sauna. They are not, it's a teratogenic exposure to be exposed to heat during pregnancy. So why not to look at this with ambient exposure? And when I've looked back in the literature, I saw that the first observation about the teratogenic effect of temperature was in 1960 with Genoa pigs that were exposed to heat during few days in Australia. So this is ambient exposure, this is animal. And starting from this, and vet, Edwards is a veterinarian, he started to do many experiments, and then epidemiological observation showed that there is association between heat and congenital malformation in humans. So the observation that there is something related to heat with ambient exposure was there. So I've started my study, and we had this publication. And since there are a few, more than 10 publications about congenital malformation, but congenital malformation, similar to cancer, is a group of outcomes. So it's a complex to do meta-analysis or to understand, but we now know that there is an effect between heat and congenital malformation. I have to say that when I prepared this presentation, I was looking for this nice photo of the Genoa pigs, which I didn't have before. And I've also found a very interesting paper, which I wasn't aware of. And I'm not learning and not studying brain development, but I saw a publication about from the 70s on Genoa pigs and the effect of heat exposure during pregnancy and brain development. So this is a very interesting, and I think it's also something that can be studied in other settings of human and epidemiological study. So in this specific study that was published in environmental epidemiology, we've looked at 135,000 births, live birth, and stillbirth, including spontaneous abortion and late abortion that occurred after gestational week 23. And we looked at the 3 types of congenital malformation, isolated congenital malformation, and multiple congenital heart defect. The outcome were atrial septal defect, ventricular septal defect, and patent ductus arteriosus, which are different malformation in the development of the heart or the artery. So first of all, this is how temperature in Israel is distributed in time. This is specifically we had only two exposures that we can use, stations that we can use. So we could not do in this specific study spatial analysis. And we calculated daily mean and daily peak. And you see that in Tel Aviv, in the summer, it's hot, very hot, but it's hot all the time. And this is the spring and the winter. You see that in the spring, it can be hotter than the summer. It can be even higher temperature, but the population is not adapted during this time. So we saw an effect to heat exposure, but just during the cold season, not during the hot season, which means probably that our population is adapted to heat. I do want to say that when I've did a reflection and read again a study that was published 10 years ago, my study that was published 10 years ago, I see some flaws in methodology that I would do different. For example, when you're looking at temperature, temperature is not something that increases in the risk that I will see in temperature. It doesn't have to be linear. So even though I did quartile of exposure, the reference category is the lowest. So now when I'm looking at this, I see that the effect here is the lowest, is the second quartile. So maybe if that was the reference, the other one was significant. So this is something that when you progress in the science and with yourself in how to be a scientist, how to be a better researcher, you see how you can improve your result later. Okay, so we did see an increase with the hot days, and we also saw an increase. The stronger was when we looked at the extreme heat event, and also when we looked at the, you see that this is the lowest relative risk, odds ratio in this case, compared to the others. So maybe now if we looked at this different, we can see some stronger associations. So in Israel, during the summer, the population is well adapted. During the cold season, the weather is less stable. That means that maybe this is the time to do intervention to the population. We are now trying to better understand the association by using models of exposure that are more accurate, using a machine learning methods from Itay Klog lab. Itay is a researcher that conducted his postdoc from Harvard with Joe Schwartz, and now he's in Boston, actually in a sabbatical also, but he's a researcher from Ben Gurion, and he also published many models in the US with temperature and air pollution. So we are going to collaborate with the data that I show you. That's one of the models, the temperature and the particulate matter. So this study is from Itay and Ra'anan Raz. They looked at live birth and in the region of the south part of Israel. This is Be'er Sheva. It's the south part of Israel. So they looked at all the births that occurred in this region. And this is a model, the grid of the model. And what they found is that temperature, increase in the temperature was associated, but with the lowest temperature increased the risk for small for gestational age. And you can see that, you see here the effect. This is a U-shaped association. So they saw a stronger effect for cold exposure. A different group looked at preeclampsia using the same exposure model, and they found that they've looked at the 3 trimester. They looked and found that the higher the temperature, the higher the risk for preeclampsia for the 3 trimesters. But when they looked at specific population, they saw that the effect was stronger for the Bedouin population. The Bedouin population is population that part of the population is live outdoor. I mean, they are in tent and not in buildings. So probably the effect should be stronger. And you see that the effect during the 3rd trimester is the highest for this population. This is effect that they see during the warm pregnancy, which are pregnancies that were exposed to the warm season most of the pregnancy. So we published the most recent publication in EHP last year about low and high ambient temperature, and we investigated singleton live birth, and we were interested in birth weight and extreme temperature. And I was also interested to know on when the exposure is most harmful, by trimester and also by gestational weeks. So we did a model using INCA model, and that is a model that is short-term projection of temperature, and the resolution is 1 kilometer and 1 hour for the entire country. And we had, as I said before, we had information about the location of the woman, of the birth, of the pregnancy of woman, of the pregnant woman. We had information about gestational weeks, trimester, and also we calculated the exposure during each one of these time periods. So this is how the temperature was distributed during the research period. That was from 2010 to 2014. You see that it's very different. It was 3 regions, geographical major regions. This is the Mediterranean climate. This is the desert, and this is the semi-desert. This is the very hot. Also, there are those most later central part. We calculated percentile of temperature according to the climatic zone. When I've started to look, I've looked at the entire population and I did an analysis for the entire Israel population. And I saw a wiggling. I saw something that didn't make sense in the beginning when I've looked at the temperature with birth weight. But then when I did analysis for separate region, it made sense, which means that the population is adapted to the temperature where it lives. We calculated centiles and we calculated term birth, and we did adjustment according to DAGs, and we used distributed lag models. So this is the DAG, how we are looking at and how did we decided what confounders we are going to use and look at. And this is how the association during the entire pregnancy exposure was seen. As you can see, we see an inverse U shape between association between temperature, entire pregnancy average temperature, and the birth weight, the term birth weight. So you see this is like the optimum temperature, approximately 20 degrees. This is in the semi-arid region. It's not the hottest one, but it's not the Mediterranean or temperate region. So we see that this is approximately 20 degrees. And the colder the temperature, the lower birth weight, and the hotter the temperature, lower birth weight. Similarly, we see the effect in the desert and also in the temperate region. But here we see that in the temperate region, the hotter the temperature, we see a stronger decrease in the mean birth weight. When I've looked at the percentile, you see that this is almost the same from 20 percentile until 60 or 65 percentile. It's very similar, but then when we look at percentile of temperature, we see very big, steep decrease in the birth weight, in the mean birth. So we were wondering, we did this also as a categories, but not only percentile. Why we did this as a categories? Because in using the model of the GAM, you cannot discuss specific exposure. What is the risk for specific ones? So I can just show a very nice graph, but I cannot explain exactly, and I cannot calculate the attributable cases. So we did the same, and we saw the same effect. Here I'm showing this is low birth weight, mean birth weight, and this is the increased risk that we see with low birth weight. But I was wondering when the exposure is the most harmful, and we did an analysis per trimester of pregnancy, and we saw that the effect is the strongest during the third trimester of pregnancy. And also, I want to show you that there is also effect during the second trimester with heat. So this makes sense. I do want to say that the categorization of gestational age and fertilization age is also something that is very important to understand when you're working on any birth registry data, and people confuse it a lot because fertilization age starts when there is a fertilization. So this graph that I've showed you about the development time of what happened. What happened? Okay. Mm-hmm. Well, if someone interested, he can read about this in my invited perspective in EHP that was published a few months ago. But it's very important methodological issue that if one of you is working on pregnancy outcomes and registry-based data, it's very important to understand it because it's very confusing. It's so confusing that even the WHO in the definition of preterm delivery, gestational age, is stating that this is a very confusing issue. So I think it's very important to understand this issue, so you can read about this. We also been wondering if a specific week, because trimester is something that people just saying trimester. I mean, there is nothing real about trimester. I mean, there are things that occur more organogenesis during the second trimester, but it's just to take the pregnancy and cut it to 3 pieces. It's not biological difference. And also weeks is not exactly biological difference, but we decided that this is a smaller scale time, and we want to know better when the association is stronger. So we also looked about the effect of exposure to heat and to cold during every week of pregnancy. And we saw that during specific time, week 31 until week 36 of gestation, we see an increase in the risk with exposure to heat. We didn't see the effect of cold with cold. So what are the future direction? First, we're going to look at satellite data, relative humidity, and dust event, heavy flood, brainstorm, maybe. Pollen, I don't have exposure, but I think it can be very interesting also. Now we are planning to look, does greenness mitigate the health effects from ambient temperature? And of course, modification of the association to look at specific vulnerable population, and also about other pregnancy outcomes. But this is more of the same, I have to say. And I also have to say is that I think that this need to be moved forward, as I explained in the beginning. So for myself, in every publication from now, there have to be an attributable cases for a specific scenario that the CEO of the Ministry of Health will be able to understand, because it doesn't understand relative risk, and most of the public doesn't understand relative risk, and how to design and how to conduct an policy intervention or something that will reduce the risk that we see, that we know from the 80s. So we have to move forward to improve things. So thank you very much for listening, and questions, please. Sorry for taking all